Hello there, it's Luke, and this is Anything But COVID, a bite-sized bit of critical care teaching. Now, on Monday, I shared this picture with you and asked you what you thought this plastic thing is in this person's neck. And it's probably a little bit unfair because this thing might be made out of plastic or it may be made out of silicone. And what some of you may have already identified is this is a laryngectomy wound or a tracheostomy as part of a laryngectomy operation. So we're going to talk about that a little bit, and then we're going to talk about what specifically this bit is in this person's neck. Excuse me. There we go. Right. So just to recap, a laryngectomy is an operation to remove somebody's larynx. And very briefly, here's the anatomy. Here's your oral cavity. Here's the pharynx, which is sort of your throat. The larynx, which contains the vocal cords, and there's the epiglottis, which prevents food and other sort of contents of your mouth travelling down into your lungs and prevents you sort of developing aspiration pneumonia. And this is what the whole sort of upper airway looks like in health. And obviously you can see at the back there you've got the oesophagus, and at the front you have the trachea. And very briefly, any procedure or surgery that ends in an ectomy means that part of the body has been removed. So a laryngectomy is where the larynx has been removed, and overwhelmingly this is for cancer, and a lot of these cancers are related to lifestyle choices such as smoking and alcohol use. And we're used to seeing laryngectomies performed mainly in older people, however, and mainly in men. However, both of those things are changing with time. So we're seeing a lot more women with laryngectomies and also a lot more younger people. Certainly locally, but I understand that's the picture nationally as well. So following as part of a laryngectomy operation, a tracheostomy is formed, and trachea, so the sort of windpipe, and ostomy means opening. So ectomy is removal, ostomy is opening. So the tracheostomy is formed as part of a laryngectomy operation. It seems pedantic, but it's worth getting your head around that terminology. And it's worth noting that following a laryngectomy, there is no communication. There's no hole between the oesophagus, the food pipe, and the trachea, the windpipe. So in theory, these people are sort of less likely to sort of aspirate or have any food go into their lungs, certainly from within their sort of throat and their oral cavity. Now, what is really vitally important that you understand is if somebody that has had a laryngectomy, indeed most people have had a tracheostomy for whatever reason, if there is an airway or breathing emergency, this should be managed at the stoma site. You can apply facial oxygen, but it just won't do a great deal for anybody that's had a laryngectomy. So if you need to give oxygen, if you need to try and perform suction, this is where your management should be, at the stoma site in the neck. And it's not always easy to tell whether somebody's got a tracheostomy or a laryngectomy, so it's probably worth having that as your first and your priority airway, the neck. And then if you do decide to give somebody oxygen via the top end, well, that's possibly a bonus. So there are lots of things that are made difficult following a laryngectomy, and one of those is being able to speak. So if you imagine you've got no sort of communication between the lungs and forcing that air out and all the structures that would allow you to form words, and you no longer have any vocal cords. Well, that's where this piece of kit comes in. So it says tracheoesophageal fistula on this presentation, but actually what we really mean is a tracheoesophageal puncture. So a small hole is made at the time, usually at the time of the laryngectomy operation, between the trachea and the esophagus. And a one-way valve is inserted, and that's the piece of equipment that you can see there in that person's airway, and that allows air to travel up through the very top of the esophagus, up through the oropharynx and out of the mouth. But as it is a one-way valve, it prevents food and saliva and all the rest of it travelling in the other direction and down into the lungs. So I've just mentioned that, excuse me. So when a person with a laryngectomy who has a tracheoesophageal puncture valve in situ wishes to speak, what they need to do is occlude the stoma site, so that as they breathe out, so they breathe in through the stoma, and as they breathe out, they occlude the stoma site and that opens up the one-way valve as they breathe out, and then they can begin to sort of form sounds. Now, the voice won't sound like their voice did prior to having the laryngectomy removed, because they've also had their vocal cords removed. But there is a voice that can be made whereby the sort of vibration of the esophagus helps form the sounds. And it takes a bit of getting used to when you meet somebody with a sort of a voice that is formed through a TOP valve. And undoubtedly it takes them a bit of getting used to as well. But it does act as a very sort of functional form of communication. Now, there are a couple of things that you need to know about top valves. One is that every now and then they could become dislodged, and they can end up in sort of one of the airways, getting trapped in a sort of bronchus or a bronchiole. And this needs to be dealt with quickly, so the person can go to the ED and then hopefully to the ENT department, and they can have a look and remove these things if that's what's required. I mean, sometimes people lose these valves and they turn up on the floor in their house. But yeah, it does need to be dealt with urgently. It's not an emergency, but it does need to be dealt with urgently. And the second thing to say is, if you are caring for somebody that has had a laryngectomy and has one of these tracheoesophageal puncture valves in place, if it is securely in place, you don't need to remove it. Okay, so let's say we had somebody on the intensive care unit who'd had another operation, maybe something going on in their abdomen perhaps, and off the back of that would become hypoxic, or needed help with suction, or perhaps had a cardiac arrest even. If they had one of these valves in and it's not fallen out or dislodged or anything like that, leave it in situ and supply oxygen and manage the airway and suction and all the things that you would do in the sort of emergency or in the deteriorating patient. But yeah, leave that valve in place. That's an important point. You don't need to be messing about trying to remove these things. Now, as I've just said, these things sometimes fall out in patients in the community or even in the hospital. And what may occur is that people may have been supplied with a Foley's catheter, so the sort of thing that we're used to putting into people's urinary tracts, into their urethras. And it makes sense. It's a sterile thing. You can blow up the balloon on the end of it and it will hold the puncture site open. So it may be that if you're in ED, or if you are attending somebody on the ward, or perhaps even on critical care, if one of these valves have fallen out, somebody may have a Foley's catheter stuck in the whole of one of these things. It's just to make you aware of it. It shouldn't be causing them any bother. It shouldn't be occluding their airway in any way, shape or form, but it just looks a bit unusual, and it's worth preparing yourself that this is something that you may see. So to sum up, I set this on Monday. I showed you this picture on Monday, and we've explained that this is a stoma site of somebody that's had a laryngectomy, and within that piece of plastic or silicone is a tracheoesophageal puncture valve, which enables somebody to speak. Okay, that's the end of this ABC Anything But COVID session. Thank you very much for listening.